Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, welcome to episode number 196, where we're discussing the association between Alzheimer's and chronic pain. My expert guest this week is Dr. Dale Bredesen. He's a professor at UCLA and the president of the Buck Institute for Research on Aging. His work focuses on the mechanisms leading to neurodegeneration, and with his research group, he's published over 220 scientific papers, leading to the first description of the reversal of cognitive decline in patients with Alzheimer's disease. His book, The End of Alzheimer's, is a New York Times bestseller and is now available in 32 languages. Okay, let's get ready and let's meet Dr. Dale Bredesen and learn about the link between Alzheimer's and chronic pain. Hi, Dr. Bredesen. Welcome to the Healing Pain Podcast. It's great to have you here today.
Hi, Joe. Thanks for the invitation.
I'm excited to talk to you about the reversal and prevention of Alzheimer's and cognitive decline. It's a topic we haven't covered on the podcast yet, but there's lots of overlaps with many types of chronic disease and, of course, chronic pain. I think a good way for us to start today for all of our viewers and listeners is for you just to kind of ease into this with what is Alzheimer's? Can you tell us what it is? And then what are the risk factors for developing Alzheimer's?
Yeah, good question. So Alzheimer's is the most common cause of dementia. And dementia is global cognitive loss. So about 2/3 of people will start with memory problems, but about another third of them will start with other problems, such as problems with planning or with word finding or with spatial recognition, navigating around areas, or with recognizing faces or objects or things like that. And this is a progressive problem. So people, as you know, they become demented, more and more demented over time. When you look at what causes that, the majority are actually Alzheimer's disease. And that simply means that Alzheimer's is really a pathology. So it shows that there are specific plaques, which have a number of different proteins and peptides in them, but the one that's dominant is the amyloid beta peptide or A beta peptide. And then it has neurofibrillary tangles, which have this component of phosphotau in them. A tau is a molecule that basically stabilizes your microtubules and stabilizes connections in the brain, and these are lost in Alzheimer's disease. So this is a major issue. As you know, there are close to 6 million people in the U.S. now with Alzheimer's disease, but this really underestimates the problem because, of course, for example, I have 2 daughters. They're too young to know whether they're going to get Alzheimer's yet or not. So if you ask the question of the about 323 million Americans or so, how many of us will develop Alzheimer's disease? The answer is about 45 million people will develop. It's incredibly common. As Professor Christine Yaffe has published, it is now the 3rd leading cause of death in the United States. So just as we've been all struggling with the COVID-19 pandemic, in fact, Alzheimer's is a much larger pandemic that's been going on for quite some time and is on the increase rather dramatically, unfortunately. You mentioned, what are the risk factors? So it's interesting. It actually has many of the things that have affected us for chronic illness. So, for example, many of the comorbidities that we hear about with COVID-19, hypertension, type 2 diabetes, obesity, poor immune system support, all of these things, reduced vitamin D and zinc as an example. These are all comorbidities for Alzheimer's disease. So in fact, what's happened with COVID-19 is you've taken the decades-long increased risk for Alzheimer's and you've compressed that into a couple of weeks. Mm-hmm. So many of the same things that are giving us ill health, metabolic syndrome and things like that, are the big risk factors for Alzheimer's. But the biggest problem of all is that doctors don't look at what's actually causing the problem. They say, oh, it's Alzheimer's, but they don't say why. You need to look at dozens of different factors. This is the future, and this is the critical piece that we have changed and that has allowed us to, for the first time, reverse cognitive decline.
Excellent. It's a great introduction. I know you talk a lot about the recontextualization of Alzheimer's. I love that word. I found that on your website, the recontextualization of Alzheimer's, which is really important. And it really just talks to everything we speak about on the podcast. For certain people, is Alzheimer's their genetic destiny, or is there flexibility in our gene expression with regard to this condition?
Absolutely, there is flexibility, tremendous flexibility. And I should say that, first of all, the point would be that 95% of Alzheimer's disease is sporadic. So in other words, you don't have genetics telling you you are going to get this. Now, you do have some genetics of risk, just as you do for heart disease, for example. There's genetics of risk, but look what people have done to prevent heart disease. So absolutely. So the 95% of us don't have a gene that says you are definitely going to get this. Now, about 5% of people have mutations that are in one of three genes, APP, presenilin 1, and presenilin 2. And those people do inherit a very high tendency, it's essentially 100% penetrance, so they will get Alzheimer's. However, we are also working with some people there, and it's not so clear that you can't impact that as well. That's ongoing research, and we'll see over time. But for 95% of us who are the ones who are going to get Alzheimer's, we can absolutely do something to prevent it, and we're seeing also reversals time and time again. The common risk factor gene is ApoE. And ApoE is apolipoprotein E. And this is the thing that carries around the fat. It's one of the fat-carrying proteins. And so we think of this kind of like your butcher. This is the guy that carries around the fat. And our studies years ago, in fact, showed that not only is this your butcher carrying around the fat, but it's also your senator making the laws of the land. It's actually changing the programming of your cells. And it's changing them into a more pro-inflammatory and protective state. So again, what we think about is Alzheimer's, as you indicated, this whole idea of recontextualization. If you look at what Alzheimer's is, unfortunately, people have had it backwards for many, many years. So when I say that, what I mean is they wait for you to get symptomatic. They don't do any prevention. Then they tell you, they look at a very small data set, or they look at a couple of things, your thyroid, your B12, and say, we don't see a problem, Joe. Okay, you got Alzheimer's. There's nothing we can do. They put you on a drug that doesn't help, and they tell you that there's nothing that can be done. I mean, all of that is completely backwards. 21st century medicine, and this is true for other conditions, chronic conditions, not just Alzheimer's, is about why. 20th century medicine was about what it is. We all learned in medical school to make a diagnosis. Is it measles? Is it a broken leg? Is it Alzheimer's? What is it? 21st century medicine is about why instead of about what. It's not just making the diagnosis. It's saying, why do you have this? And by the way, this, of course, refers to people with chronic pain. And as you pointed out, they are actually at increased risk for cognitive decline. So they should absolutely be getting checked, what we call a cognoscopy, and getting on prevention. So the idea here, 21st century medicine, we want to know, we look right now at 150 different variables that all contribute. We want to know if you have specific pathogens. For example, there's a link between recurrent herpes simplex that's untreated and cognitive decline and Alzheimer's. There is a link between P. gingivalis, one of the oral bacteria that actually is associated with plaque in your mouth. So if you have bad teeth, you are actually at increased risk. We want to know that because it can be treated. If you have increased homocysteine, reduced vitamin D, if you have pathogens, toxins, all of these things are contributors. And the idea that there's one cause is biologically naive. You want to identify the contributors. And typically, by the way, we find between 10 and 25 different contributors when someone has cognitive decline. And then we address all of those with a precision medicine, personalized protocol. And that's the whole idea.
So in essence, what you're saying with this recontextualization of treating Alzheimer's, instead of looking at, okay, there's potentially a gene that turns on, and the only way to reverse or cure, quote unquote, this disease is to turn off that gene. That's old news. Exactly. So the new information is, how do we look at the entire context of someone's health span and their life, and how that influences not only their genes, but also all the different cellular mechanisms, and in essence, their systems biology, how it influences their entire expression of this condition. I'd like you to just talk a little bit about ApoE4
Yeah.
And that APP, that amyloid precursor protein, because I'm reading some of your research. I was reading that you did a really nice job at comparing Alzheimer's to, let's say, osteoporosis, and this synaptoblastic versus synaptoclastic balance or imbalance.
Yeah, thanks for mentioning that. So you mentioned ApoE4. Just to start there, we all have two copies, just like other genes. We have two copies of the ApoE gene. And it comes in three different alleles, essentially 2, 3, and 4. You inherit one from your mother, one from your father. And so, for example, the most common is ApoE33. And I checked myself, I'm a 3-3, for example. That's kind of vanilla. It's kind of the typical one. But ApoE4 is the one that gives you increased risk. So if you have 0 copies of ApoE4, which 3/4 of us have, your risk for Alzheimer's over your lifetime is about 9%. It's not 0, but it's not terribly high. If you have a single copy, which 75 million Americans do, and most don't know it, this is again why we recommend check it out and get on prevention. Let's make this a rare disease, which we can now do. Then if you've got a single copy, 75 million Americans, your risk is about 30% during your lifetime. If you have 2 copies, which about 7 million Americans do, then your risk during your lifetime is well over 50%. Most likely you will develop Alzheimer's during your lifetime unless you get on appropriate prevention, or please get treated. If you don't do that, please get treated at the earliest change, as you notice the earliest changes. So that's ApoE, and it turns out ApoE is something that is protective but gives you a pro-inflammatory state. And as you know, pro-inflammatory state associated with aging, associated with cardiovascular disease, associated with many other things, and including Alzheimer's disease. Now, you mentioned APP, and I'm so glad you did, because it's the way these things play out. So APP is a protein that sits in the membranes of your cells, especially in your neurons, and especially near the synapses, where the neurons are actually connecting. And you have nearly 1 quadrillion connections in your brain. You know, we have a tremendous supercomputer inside our skulls, which has about 100 billion neurons, and on the average, nearly 10,000 connections per neuron. So you have close to 1 quadrillion connections. Really, truly an amazing brain inside our skulls. Now, what happens is there's a whole set of things that essentially give you a synaptoblastic signal. In other words, when things are good, your brain is saying, okay, I can make new synapses, I can build and maintain. And you know, when you've had good sleep and things are going well, you learn very well. And when you're under a lot of stress and you haven't had any sleep and you've had poor nutrition and you've got an ongoing inflammation and all sorts of problems, you learn and remember less well. And so when we started to look 30 years ago at what is Alzheimer's, that was the whole question. Could we understand the fundamental nature of this problem enough that we could actually begin to fashion the first effective preventions and treatments? What we found is that APP, this thing sitting in this membrane, functions as a molecular switch. It's really striking. It's a little bit like having, let's imagine that you're the president of a country called Bredesen. So, okay, when things are good, you as the president say, we're going to make new structures, build new bridges, interact with new countries. That's just what your brain does. And APP in that case is cut at a single site and produces 2 fragments, 2 peptides, SAPP alpha and alpha CTF, that do just that. They signal and say, things are good, let's make connections, let's remember things. Great. Now, when things are bad, so let's say in your second term as president of Bredesen, and you've got pollution, and you've got people invading you, and you've got all sorts of problems. You don't have any money in the coffers anymore in the national treasury. Then what do? You say, oh my gosh, I can't build. I have to downsize. I have to protect myself, especially if you've got invaders coming across the borders. And by the way, your brain does the same thing. So your APP recognizes this. It's literally integrating signals from all sorts of different things. Your hormone levels, your nutrient levels, your trophic factor levels, your level of inflammation, all these things. And so what it does, it's literally saying time to protect ourselves and pull back. So if you're a president of my Bredesen, you say, okay, we're going to kill the invaders. We're going to use napalm, which now means we have less arable soil. You're literally making your country a little smaller because you've got a war zone. That's exactly what's happening in your brain. So the first part is the when things are good, that is synaptoblastic signaling, making and keeping synapses. Again, just like with osteoporosis, as we age, if we don't have the right nutrients, hormones, etc., we can't make new bone, and we start losing our bone, and we start developing osteoporosis. Alzheimer's disease is synaptoporosis, because now when you don't have the right support, when you've got invasion from mouth organisms or from systemic organisms, you are protecting yourself against those. You're trying to kill them, and in so doing, you are now retreating. It's a brain in retreat. That is synaptoclastic signaling. And everybody with Alzheimer's has too little synaptoblastic signaling and too much synaptoclastic signaling. So what we've done then to translate this research to the clinic is to look at each person and ask, what are the things that are contributing? Why are you on the wrong side of that balance? And then what we want to do is increase the synaptoblastic signaling, decrease the synaptoclastic signaling, and that has given us unprecedented improvements in people with cognitive decline. We published the first examples of reversal of cognitive decline back in 2014, and then, of course, published a book on this in 2017, which was it's now in 32 languages and was on the New York Times bestseller list for 5 months. So we're now seeing this reproducibly. Many thousands of people are now on this protocol. And of course, not every single person responds, but many do. And the critical piece is to identify what's actually driving that decline.
Yeah, and of course, for the practitioners, I was reading through some of Dr. Bredesen's work last night, so I encourage you, of course, to go on PubMed and check out his studies. And for everyone, you can check out The End of Alzheimer's, which is his New York Times bestselling book, which is available, of course, on Amazon and other places. So I just want to go back to that idea of a molecular switch that we've discovered. So the molecular switch, in essence, maintains the synaptic cleft. So in essence, maintains healthy nerve function.
Yeah.
It repairs, or it has the ability to repair that cleft or that nerve function. Can it remodel? Because repair and remodel is similar, but not exactly the same.
Yeah, that's a good point. So what it's essentially doing is deciding whether there is reason to pull back or whether there is reason to go forward. Mm-hmm. So in this case, in this point, it is part of neuroplasticity. And you can see now it makes a lot of sense why this is a disease of neuroplasticity. So it's a good question. We don't know if it can remodel once the synapse is already there. We know for sure it can destroy the synapse. So in fact, the amyloid produced by APP very rapidly, and there's some beautiful research on this by people like Professor Ed Koo and others, showing that if you actually put the A beta on the synapse, it literally will destroy the postsynaptic element. It will literally pull back. So this is about going forward, pulling back. And in fact, you also can, with this, pull back on the neuron and ultimately collapse it and ultimately kill it. So there, as you indicated, there are all sorts of levels of interaction, from changing the chemical communication to changing the anatomical communication to pulling back on the axon and ultimately killing the cell itself. And, people have compared synapse formation and maintenance to marriages. So, there's courtship and, there is commitment, there is marriage, and in fact, there is decommitment. There can be divorce, unfortunately. And so, in fact, these elements, the presynaptic and postsynaptic element, communicate with each other. And of course, obviously, in pain research, there are issues about the abnormal communication that can happen with these connections. And so in this case, you've got this ongoing communication, and you can basically say, this is not working for me, and literally pull back. And unfortunately, when you have these various insults, and again, it tells us Alzheimer's disease is a protective response to these insults, but part of that protection is pulling back. And, this is very similar to what's happened with COVID-19. We're all protecting ourselves from COVID-19, but it's at a price. We're going into our homes. We're not able to do the business we once did. Look what's happened to our schools. Look what's happened to our sporting events. This is very similar to a brain that's in retreat, that's trying to protect itself. So therefore, we want to know, what are those insults from which it is trying to protect itself? Let's get rid of those. It also tells us the pharmaceutical companies that have said, oh, just get rid of the amyloid and everything will be fine. That has not worked. And we can see why now, because you have to get rid of what's causing the amyloid. In the long run, I think it's going to be very helpful to get rid of the amyloid. But we've seen a number of cases now where people lowered their amyloid without lowering their toxic burden or their pathogen burden, and they clearly got worse. So in fact, you need to address the upstream causes.
Excellent. So of course, a lot of what you're talking about is the basis of plasticity, of neuroplasticity, which is important in Alzheimer's, cognitive decline, chronic pain, pretty much anything that involves the nervous system, which is almost everything, every condition in your body. I know in your earlier research, you identified 3 subtypes of Alzheimer's. I believe that's now grown to 6. Can you walk us through those a little bit? Because I really love the kind of that framework again of different types of Alzheimer's and different exposures, if you will.
Yeah, again, as we begin to look at why people actually have this, and that's the key, we start to see that they fall into subgroups. And we first published this back in 2015. And so, we tell the patients, imagine you have a roof with 36 holes in it, and you got to patch those different holes. You got to find out what they are first. So as we started to look at, what's actually driving this, and this started with APP. Okay, so we now know that APP can go one way, can go the other way, can go the good way or the bad way. Okay, what are the things that drive it to the bad way? Well, it turns out that they tend to be in groups, and it turns out there are 6 different groups. So if you have ongoing inflammation, and this can be from P. gingivalis, as I mentioned earlier, T. denticola, F. nucleatum, HSV1, HHV6A, Borrelia, Bartonella, lots of different chronic pathogens. They have in common that they tend not to be acute pathogens. It's not pneumococcal pneumonia. These are chronic pathogens like Lyme disease and tick-borne organisms and things like that. You've got a chronic inflammatory state, and again, just what's seen in cardiovascular disease. Part of the response, and this has really been interesting to me, the amyloid that is produced by APP, and APP is the father of the amyloid that's produced, the amyloid is part of the innate immune system. So again, this is part of your inflammatory response. Just as, again, COVID-19 killing us with cytokine storm, these pathogens are killing us by telling us to make A beta to fight the pathogens, which is downsizing, damaging our synapses. So that's type 1 or hot Alzheimer's, inflammatory, and you typically see the high sensitivity C-reactive protein, hsCRP. So we recommend that everybody please check your hsCRP. It's important for your cardiovascular disease, but it's also important for your risk for Alzheimer's. Then type 2 Alzheimer's is atrophic. You can get to the same, you can imagine this easily. You can have to pull back either because someone's attacking you and you're fighting them, or because you just don't have enough money. You don't have enough support. So you want to give yourself Alzheimer's disease, get rid of all your trophic factors and all your nutrients and all of your hormones. So as you know, big risk for people who have sudden drops when they're relatively young of estradiol. That's one of the common nice studies out of the Mayo Clinic showing that people who had an early oophorectomy at the age of 40 or younger and who didn't have hormone replacement therapy doubled their risk for Alzheimer's, even though the Alzheimer's came on years later. So again, your APP is responding to this support level. And if you drop your vitamin D, drop your B12, increase your homocysteine, drop your estradiol, testosterone, pregnenolone, progesterone, on and on, thyroid hormone. All of these things are critical supports, nerve growth factor, brain-derived neurotrophic factor. These are all critical supports for your synaptic production and maintenance. So that throws you again into a synaptoblastic state. You simply cannot afford those 500 trillion plus synapses, nearly a quadrillion synapses. So that's type 2 or cold Alzheimer's. And then there's one that actually has some of both, which is type 1.5, which is glycotoxic. This is literally sugar-induced Alzheimer's because And there's actually a striking relationship between sugar and Alzheimer's disease, because as so many of us, about 80 million Americans, have insulin resistance, incredibly common. And this is because our diets have more simple carbs than we are actually made evolutionarily to handle. So what do? Of course, we ramp up our insulin. We end up getting insulin resistance, which is shown in the vast majority of people with Alzheimer's. Literally, you can trace the molecular pathways. The IRS1, which is one of the signaling molecules downstream from insulin, becomes phosphorylated to shut it down. It's as if you were living with a son who's playing loud drums all the time. And so, you got some earmuffs for you and for your spouse. And then, of course, your spouse puts on a Brahms lullaby. You can't hear it. And that's exactly what happens to our brains. Our neurons depend on insulin as one of the growth factors. So when you can't respond to insulin, you start downsizing. You start losing these synapses. That's type 1.5 or glycotoxic or sweet Alzheimer's. Then type 3 is toxic. And the toxins come in 3 different kinds: metals and other inorganics. You live around air pollution, you have too much mercury, things like that. Organics, things like toluene, formaldehyde, benzene. Then the third one is biotoxins. And we find many people who don't realize that toxins produced by molds, for example, actually do increase your risk for Alzheimer's. Many of us living in places, now it's not all molds. There are 5 big groups. So there's Stachybotrys, Penicillium aspergillus, Wallemia, and Chetomium. Those are the big 5. And so, you can easily check your house. There's something that the Environmental Protection Agency put out called an ERMI score, ERMI, for EPA Relative Mold Index. You can check it in your house really easily. You want your score to be less than 2 in your house. If you're sitting up there at 8, 10, 12, you've got some concerns because you've got molds in your house that are far too high. Then you need to check to see if you've got exposed to these toxins. And we see this all the time where people come with Alzheimer's for no reason. And when you actually check it, you find out that's the thing. So that's type 3, toxic Alzheimer's. Type 4 is vascular, also very common. If you don't have enough vascular support, that increases your risk for Alzheimer's. And one of the most common things we're seeing is people who have sleep apnea or have decreased oxygenation at night. Incredibly important to find out whether you have good oxygen saturation. It should be in the 96% to 98% range. And we're all concerned about oxygen saturation with COVID-19 again, and you can even check it during the day on your iPhone. And so that's type 4, vascular. And then type 5 is traumatic. And if you've had head trauma, you are at increased risk for cognitive decline associated with Alzheimer's. And of course, also at increased risk for CTE, as was shown in the film Concussions. So these are all, or concussion. So these are all the subtypes, and different people have different drivers. We need to identify those and address those drivers of cognitive decline.
Excellent. I love that framework of those different subtypes. And I think everyone should kind of, rewind that and play it back and listen to it. If you're a practitioner, of course, you can read about it on the blog because all of it will be transcribed. Of course, we're talking about cognitive function and brain health. In any of those different subclasses, is depression or anxiety a trigger for Alzheimer's, or is it just a part of one of those subtypes?
No, it's a really good point. And depression is especially common. For years, people said, you don't have, when people would have trouble with their thinking, they go to the doctor and the doctor says, it's just depression, it's not Alzheimer's. Well, it turns out they're much more closely related. They used to also say, it's vascular dementia, not Alzheimer's. Again, these are closely related. So depression and anxiety are both relatively common precursors for dementia. And what we've found, so again, if someone said you have dementia, be careful, make sure that you're doing okay with your cognition. Your cognition should begin to come back and be back to normal as you are recovering from the depression. But again, it is associated with risk. As you know, depression is associated often with systemic inflammation, which is again one of the precursors for Alzheimer's, one of the risk factors. So we've found especially it's associated with the toxic subtype. So people who have type 3, and we hear this story all the time, especially for people who are in their 40s and 50s, because it's the young people that tend to get the type 3 toxic, whereas the older people are the ones that tend to get the type 2. Type 2 especially is more a disease of your 70s, type 1 a disease of your 60s, type 3 is more a disease of your 40s and 50s. And again, I should say, by the time that you get a diagnosis, the underlying changes have typically been evolving for about 20 years. So therefore, what we used to think of as a disease of the 60s, 70s, 80s, it's really a disease of the 40s, 50s, and 60s that's playing out over time, and then you get a diagnosis later. This is, again, why we recommend everybody, please get evaluated. Please get a cognoscopy, just as you'd get a colonoscopy when you turn 50, but when you turn 45, or if you're older than that, or if you've got a strong family history, please get evaluated. So absolutely, the depression tends to suggest type 3. The young people in their 40s and 50s that are getting cognitive changes, again, suggest type 3. And people who start with a non-amnestic abnormality, so people are having trouble with planning. The typical story is, I can't do my job anymore. And yet it can be memory sparing early on. Not always, but it can be. And then memory is affected later. So if you're having trouble with navigating, or if you're having trouble with planning things, or having trouble with doing your job, or learning your new iPhone, or word finding, or recognizing and remembering faces, these are things, please get evaluated. This is true. Depression, common as a harbinger of type 3 toxic Alzheimer's.
Excellent. So, of course, a lot of this information you can find at drbredesen.com, and, of course, in his book, The End of Alzheimer's. I want to turn now to your Recode Protocol, because, of course, all this, you've spent decades studying Alzheimer's and cognitive decline, both the etiology as well as the treatment. You've put it into a nice program for people. Let's start with nutrition. So people who listen and follow this podcast are familiar with the Mediterranean diet. They're familiar with a basic elimination diet, and they're familiar with the lower carbohydrate ketogenic diet. Which type of diet would you recommend for the majority of patients that you see who have Alzheimer's?
Yeah. So let me preface that by saying what our research showed is that this is a disease that has many different contributors. And even for one person, there's typically several, as I said, 10 to 25. So people will have some degree of inflammation. They'll have some degree of reduced hormones or trophic factors or nutrients. So they often have some toxic exposure. So they often have some multiple subtypes. Often one is dominant, but they'll have multiple. So therefore, we realize we have to attack all of these things. So there's a core. It starts with basics. And then for each person, we need to look at, are there specific pathogens that we need to eradicate? Are there specific toxins that we need to remove? All these sorts of things. So yes, it helps to everyone start with the right nutrition, exercise, sleep, stress, brain training. Those are kind of the big 5 at the beginning, and then detox and pathogens and things like that after that. So for the diet, we use what's called KetoFlex 12-3. And the idea is the thing that works best for cognitive decline, and this is published in multiple studies, is a plant-rich, mildly ketogenic diet. We like to get people to check their ketones, and they should be between 1.0 and 4.0 millimolar beta-hydroxybutyrate. We're hoping that it'll be just as good to do breathalyzer in the future, that we're evaluating that right now. So far, the best way to do it is actually to do the little finger prick and just check your ketones. You don't have to do it that often, but to check that you get into some mild ketosis. And you already indicated, things like this. This is going on lots of places for many different reasons. But for the brain, the thing that works the best is for it to be plant-rich. You can be, it's flexitarian. You can have some meat or fish or not, as you wish. For people who want to be vegans, no problem, or vegetarians, no problem. And for people who want to have fish, meat, great. Make sure it's wild-caught fish. Make sure it's pastured chicken. If you're going to have some chicken, beware that there's some arsenic in many chickens. Be careful about that. So do, salmon, mackerel, anchovies, sardines, and herring. That's the smash fish. Those are the little guys that give you the good omega-3s without giving you all that mercury. So that's, and then I should say KetoFlex, what's 12-3, what this means is You want to have fasting. Fasting turns out to be incredibly good for your brain. Surprised the heck out of me as a researcher. And again, as a researcher for 30 years, I didn't think what we were going to end up with would have anything to do with whether you ate fish or not, anything to do with various vitamins. I thought that stuff was all hokey years ago. Well, it's turned out I can't deny the science. It shows where things actually go with your APP signaling. And so, in fact, fasting turns out to be very, very helpful. And it does activate, it activates autophagy. It gives you more ketosis. One of the things that ketones do, really interestingly, is to increase your level of brain-derived neurotrophic factor. They literally remove an inhibition to produce the protein from that gene. Very interesting. So all of these things show you want to get 12 to 16 hours. If you're ApoE4 negative, and we recommend everyone find out their ApoE status, easy to do. You can do it on 23andMe or lots of other ways. And so that you want to have 12 to 14 hours if you're ApoE4 negative, 14 to 16 hours, and some people even go longer. People will do a time-restricted eating and go to a 6 or 8 hour window to get yourself some fasting. Now, again, you have to look at what is your BMI. If you're incredibly thin, be careful, of course, and you want to then make sure you go through cycles and you get some more carbs once a week. But in general, you want to have a low-carb diet. Carbs definitely, especially simple carbs, very contributory to cognitive decline. One of the things we're seeing is that people with continuous glucose monitoring, again, a very helpful thing. There are all sorts of so-called biohacks that we can now use, people can use to help themselves, checking everything from blood pressure to glucose to ketones to oxygenation, all these things, easy to do now, heart rate variability. The quantified self is becoming more and more important for those of us to know, for those of us interested in avoiding chronic illness. So that's the diet part. KetoFlex 12-3. It is similar in many ways to the Mediterranean diet, but specifically biochemically, you do better if you induce this state of ketosis. And for the first couple of months, we recommend people, if they can't get into it endogenously, no problem, simply take some ketones. You can do this by taking ketone salts or ketone esters, or you can do it by taking things like MCT oil or coconut oil. Be careful if you're taking the oils. You can increase your LDL particle number, so you want to check, and you can basically then use the unsaturated fats in balance to make sure that you don't go too high and hurt your lipid profile. And again, we go into this in the book and in the new book, which is coming out August 18th. So there's a lot that you can do. And then exercise critical. You want both some strength training because that improves your insulin sensitivity, and you want to have some aerobics. So both of those, that improves oxygenation. Blood flow to your brain turns out to be, again, more important than we ever were told in the past. And then sleep. Sleep is one of the most misunderstood and underappreciated preventions for Alzheimer's disease. If you have a reduction in your oxygenation while you are sleeping, which so many of us do, then in fact that correlates directly with a reduction in volume of different regions of your brain, including ones that are critical for Alzheimer's disease and for memory formation. So again, very important to make sure that you're getting enough sleep and that it's high quality sleep. And we see this all the time, people not getting enough sleep or dropping their oxygenation at night, contributing to their cognitive decline. And then stress. Again, as your cortisol goes up, your stress level goes up, your brain size goes down. And that's been published repeatedly. So again, another contributor. And then brain training, very helpful. Again, brain training by itself has kind of gotten a bad rap because people doing that and nothing else may not do as well. But in the background of all the rest of the protocol, very helpful. And then optimizing hormone levels, critical. Then there are, again, supplements have gotten a bad name because when you just take a supplement, people will tell you if you just take this one pill, you're going to reverse your cognitive decline, which is ridiculous. Again, 36 holes in the roof. The supplements are good for a couple of holes. They are helping for some of these things. They're helping you get into ketosis. They're helping you optimize your vitamin D, for example. They can help you increase your brain-derived neurotrophic factor. So there are all these good outcomes you can have, but again, you need to do the other pieces or you're hurting yourself. So we got to give the concept of, you've got a house that's burning down. Don't do just one thing. Trying to rebuild the house as it's burning down makes no sense. Put out the fire and then rebuild the house. So that's the critical piece. So you've got to have the right hormones, the right nutrients, the right trophic factors. And then making sure that you've got the appropriate vascularization. And this, again, for some people, using something called EWAT, exercise with oxygen therapy, can be very helpful, again, to get the right amount of blood flow. So there is a personalized program. We have a computer-based algorithm that shows you, here are the things that are contributing to your decline or your risk for cognitive decline. And then we call this Recode, prevention of cognitive decline, versus Recode, reversal of cognitive decline. And the bottom line is that Alzheimer's should be a rare disease and can be a rare disease if everybody has the appropriate prevention and treatment, and especially early on treatment. So please don't wait. So many people say, well, I'm going to wait till I'm worse. I'm not that bad yet. That's the opposite of what you want to do. You want to get in early.
Excellent. So I have just a couple of questions based on, I love the lifestyle approach because you went through all the major 5 factors of lifestyle, which are key for everyone, really no matter what your condition is, but especially with regard to cognitive decline. So let's go back just a little bit. Earlier in the podcast, you mentioned that APO, that lipoprotein ApoE, yes, shuttles fat around.
Yep.
To bring that into the treatment aspects of it, you're talking about a mildly ketogenic diet, so mild ketosis, so not in full ketosis, but mild ketosis, kind of a Mediterranean style diet, but lower in carbohydrates.
Right.
Where you have that 12-3 approach where you're fasting for 12 hours overnight, ideally, and there are 3 hours where you don't eat between dinner and bed.
Right.
If I were to go into PubMed right now and look at high fat diets being a risk factor for Alzheimer's, I might find some research supporting that. So how does that contrast with a ketogenic diet, which people hear right away, well, ketogenic is a high-fat diet, so that can't possibly help with this condition?
Yeah, I'm so glad you brought that up because that is a common misunderstanding. And there are so many misunderstandings in the Alzheimer's field because people will isolate one variable and then try to apply it out of context. So absolutely, if you want to give yourself Alzheimer's, and I wrote a whole chapter on this, in the book, how to give yourself Alzheimer's, to let people know that, hey, and recognize, hey, I'm doing a lot of these things already. So if you want to give yourself Alzheimer's, what you want to do is have a high simple carbs. Go out and have a cheeseburger, Coke, and French fries every day. You'll damage your liver, of course. You'll get metabolic syndrome, and ultimately you'll get cognitive decline. You'll also have vascular disease, so forth and so on. So when you damage your blood vessels and you get metabolic syndrome, so you increase your insulin resistance because you've got those simple carbs, and then you get the saturated fats. That's the worst combination. In fact, Dr. Mark Hyman has pointed out that there's a horrible triad, which we call the Bermuda Triangle. It's kind of like the Bermuda Triangle, but this is the Bermuda Triangle. So you don't want to combine 3 things, and those are saturated fats, which you're going to get in, hamburgers and things like that, butter, stuff like that, which, by the way, without the simple carbs, they can be very helpful, but it's with the simple carbs. And so, when you're having simple carbs, so then simple carbs, those 2 together, and then low fiber. That triad is incredibly damaging to your vessels, to your heart, and to your brain. So that's why when you go out, you look it up on PubMed and you say, oh, high-fat diets, high saturated fat, that's going to kill my brain. Yes, if you've got a lot of carbs on board. However, people get very good lipid profiles when they reduce those carbs, specifically the simple carbs, get rid of that sugar. We were really only evolutionarily designed to handle about 15 grams of simple carbs per day. We're not designed. It's a little bit like, jumping off a roof. We just weren't meant to. You start doing that every day, you're going to get, arthritis. You might kill yourself. You might get a broken leg. And so we weren't meant to do certain things, and our bodies simply can't handle that degree of simple carbs. And unfortunately, we're exposed to it all the time now because of processed foods and because of the food industry.
Yep.
So once you get rid of those, having a high fat and intermediate protein diet is very good. You will not get the bad lipid profile, and you will not get the bad cognitive profile. So that's the misunderstanding. It's looking at the whole thing together as opposed to just one component.
Yeah, I agree. And of course, some of the guidelines I think are extremely lenient, like the American Heart Association guidelines, even for how much added sugar you can have. I tell practitioners all the time, if you have people who have metabolic syndrome or pre-diabetic or diabetic, even that is way, way too generous for these patients. So I'm sure it holds true with this. One more question along those lines. Oftentimes people ask about statins.
Right.
Statins have a place in the effective management of Alzheimer's.
Yeah, so the best situation is where you do the right things with your diet and exercise and sleep, and you don't have to get on a statin. You shouldn't need a statin. If you do the right things, if you're not eating the wrong stuff, then in fact you won't need one. Once people are already on them, what we usually say when people come in is, don't change what you're on. We're going to fix all the other things. And then after that, after you've begun to see some improvement, we can now slowly wean you off these things. And by the way, I should say, when people get on the protocol that we develop, we see this all the time. They can get off their statins. They don't need those anymore. They get off their anti-diabetes drugs. They don't need them anymore. They lose their type 2 diabetes. They get off their anti-hypertensive drugs. They don't need, again, hypertension is because something is going wrong. You can fix that. And so all these things that they needed before, they can begin to get off, because those are literally, they're allowing you to do all the wrong things. You want to be able to do the right things. Now, of course, that means changing some behaviors, and that's hard for all of us. And so, but there's all sorts of interest now in how to take micro steps, how to make small changes, one change at a time. As Arianna Huffington was just saying in her Thrive Global, instead of going from, seven sodas today to 0, go from 7 to 6.5. Okay, and then you're going to go down to 6. Go slowly and ultimately do the right things. And when you've got cognitive decline, really you have a choice. You're either going to be going to a nursing home, or you're going to be getting on the right things and getting better. And so that's a really strong incentive to do the right things over time. And again, there are all sorts of workarounds. That's the good news. Many people will say, well, look, I can do A, B, and C, but I can't do D. Okay, do some of the things. The very first woman back in 2012 who improved, and I should say the most important thing is people get improvements, sustain their improvement. And that's just unprecedented. When you get on a drug, you may get a little bump and then you go right back down to, you're right back to declining. The people we have over 8 years with sustained improvement. So she did 12 out of the 36 things. She wasn't able to do them all. That's okay. It was enough. You close enough of those holes, the other ones actually snap shut, which is the good news. You've gotten over that threshold. You've gone from synaptoblastic signaling to synaptoblastic signaling. And that's just what, and again, by the way, Dr. Dean Ornish saw the same thing with cardiovascular disease 30 years ago, and showed that once you get over that hump, you're now starting to pick up the plaque in your artery instead of laying it down. So this is the same sort of story. Do what you can, get workarounds where you need to, and you'll do much, much better.
Speaking of people making positive steps forward and making progress, how many people have you helped now and put through your Recode protocol?
Yeah, so there are over 5,000 people who are now on the protocol. In fact, you can go on apoe4.info. It's a wonderful website started by Julie G., who's an ApoE44, who's doing very, very well. She's now 8 years in. She's gone from 35th percentile to the 98th percentile in her cognitive testing. She's absolutely brilliant, amazing lady, and actually wrote part of this next book with me. Along with my wife, Dr. Aida Lasheen. And so she's been fantastic and started this website, apoe4.info, and the vast majority of those people are on some version of the protocol. We recently published, the main issue, I should say, is for a lot of people, we don't have enough follow-up information yet. People will either not get a baseline, and then we know they improve, but we can't compare it to something because they didn't get the baseline. But the ones who do, we see repeated improvement. And we published 100 examples in 2018 who all had their baselines and then all showed sustained improvement. We're actually just working on one right now where we have PET scan improvements, MRI improvements, cognitive scoring improvements, just striking improvements on all these different quantitative tests. One of the interesting things in follow-up has been looking at the electrophysiology, so looking at quantitative EEGs, looking at evoked responses where you can see improvements that you can't really deny. This is not a placebo response. These are objective and sustained improvements. And by the way, when you go off, and we've had people go off, and then about 7 to 10 days later, they will begin to see some decline, and then they go back on and they'll improve once again. So there is a time linkage to people getting improvements. So the bottom line is we actually don't know how many people have shown improvement because we haven't had the documentation for all of them. And that's one of the things we're doing right now. We're in the middle of the first clinical trial. We tried to do a clinical trial when this all started back in 2012. It was turned down because the IRBs said, oh, you're doing a multivariable trial. You can only change one thing. Well, we said, well, hey, that's not the way this disease works. You have to change multiple factors. This is a systemic problem, systems biology problem. So we were finally okay to do this in 2019. We were finally allowed to start the trial. It will be completed in December of 2020, and so it should be published in 2021.
Excellent. Well, we'll have to have you back on once that clinical trial comes out. I'll watch out for it, definitely. And of course, I know you have a new version of your book, The End of Alzheimer's, that's coming out in a couple of months. But tell our listeners how they can learn and follow you in the future.
Yeah, thanks. So you can go on to drbredesen.com or also apollohealthco.com. And so Apollo Health was set up specifically to write code and to do these algorithms because we need, again, 21st century medicine is about getting larger algorithms and getting a larger data sets, looking at what's actually causing the problem. In our trial that I mentioned, all the previous trials predetermined treatments. Oh, hey, we're going to give this drug or this lifestyle change, whatever. This is not the way to go. What you want to look is what caused it for each person, and then you want to address those things. So this is, as you said earlier, personalized. So you can look through drbredesen.com or mycognoscopy.com or apollohealthco.com.
Excellent. And we'll link to all of those in the show notes so you can access that URL. But once again, it's drbredesen.com, apollohealthco.com, and mycognoscopy.com. And of course, you can search for his book, The End of Alzheimer's, on Amazon or wherever books have been sold. So I want to thank Dr. Bredesen for being on the Healing Pain podcast this week, helping us make Alzheimer's a rare disease. Make sure you share this episode out with your friends and family on Facebook, Twitter, LinkedIn, or in a Facebook group where people are talking about how to reverse Alzheimer's and cognitive decline. I'm Dr. Joe Tatta, and we'll see you next week.
Thanks, Dr. Joe. Appreciate it.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit Integrative Pain Science Institute.com. That's Integrative Pain Science Institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.